So lab 2 deals with the axial skeleton. So as you'll recall from lab 1, the axial skeleton would include the skull that we can't see here, and then the vertebral column, and then bones associated with the vertebral column, so the ribs and the sternum. So when we look at the vertebral column, we'll notice that the human vertebral column has curves to it. So this is a curve that kind of curves backwards, and we have an anterior curve, then we have a secondary backward curve, and then when we look at the sacrum here, it's got an anterior curve to it. So when you're in fetal position, your entire vertebral column would be in an anterior curve. So we call anterior curves primary curves. And then secondary curves develop as muscle maturates and babies begin to hold their head up and hold their torso up. So because of the attachment of ribs to the sternum, then the thoracic region maintains a primary curve. So the thoracic curvature is a primary curvature. And then because the vertebrae that form the sacrum are fused, then what we would see anteriorly here is that there's a curvature of the sacrum. So our primary curves are the thoracic curvature and the sacral curvature. Secondary curvatures occur because of muscle connecting to and applying force to the vertebrae. And then the curvature of the vertebrae gives us pivot points and leverage points to stand erect. And so the cervical curvature here, you'll notice, is actually curved posteriorly, so it's a secondary curve. And then your lumbar curve is the same way, so it's curved posteriorly, so we refer to that as a secondary curve as well. Now, from a pathologic standpoint, which we can depict on this flexible model, we have some abnormal curves that occur because they're exacerbations of primary curvatures of the body. So kyphosis, which we would commonly call hunchbacked, is created because we have too great curvature in the thoracic region, so that the vertebrae are not in line with their curvatures, but actually curve anterior. So this one's greatly exacerbated. And then the other one, which would be a change of a primary curvature, would be an exacerbated lumbar curvature, so that the lumbar curvature is too great. And then that causes someone's posterior buttocks to protrude outward, and the alignment of their body is slightly off. So this one's called lordosis. So it's an easy one to remember because lumbar starts with L, lordosis starts with L, and so it defines the curvature for you. Now, the most common that we see, which is environmentally influenced, is actually when you look at the vertebral column from the posterior, and what you actually see is a lateral curvature of the spine. And so a lateral curvature of the spine is called scoliosis. And scoliosis can occur due to trauma like car accidents, bike accidents, motorcycle accidents, and can be naturally occurring because of the developmental process. And so when somebody has scoliosis, if you look at the line of their hips and the line of their shoulders, then somebody without scoliosis, these lines would be parallel. But typically someone with scoliosis either has a tilt to their shoulder or a tilt to their pelvis. And so you can actually see it when you look at how they stand or their posture. So the next thing we want to look at is we want to look at the vertebral column and its component parts. So the vertebral column is made up of irregular shaped bones that we call vertebrae. And then each vertebrae has a pattern. And so we're going to use lumbar vertebrae first because they're the largest vertebrae and will be easiest to see things on. And then we'll go back and we'll look at some modifications to the vertebrae in different regions, from the thoracic vertebrae to the cervical vertebrae going upward, and then from the lumbar vertebrae downward toward sacral vertebrae and coxial vertebrae or tail vertebrae. So all vertebrae have this large bony area that we call a body. And what we'll see is the body is smallest in upper vertebrae and becomes larger as we go down toward lumbar vertebrae. And the reason is that each vertebrae is carrying the weight of the body above it. So when we get to the last lumbar vertebrae, which would be the fifth, then it's carrying all the weight above it. And so the bodies get much larger. And then what we have is we have a hole through which the spinal cord would travel. And so this hole is called a vertebral foramen. And then what forms the vertebral foramen is a bone arch that goes over it, which we call the neural arch. And the neural arch is made up of the little feet, so where the arch is connected to the body of the vertebrae right here, which is called a pedicel, and then this real flat bony surface on the top of the arch right here, which we call a lamina. So when we look at the neural arch, it's actually a pedicel, lamina on the other side, and pedicel on that side. So it's a repeating pattern. And then when we look at the neural arch, we have projections off of the neural arch that are attachments for muscle. So a big projection that comes off the posterior aspect of the neural arch would be the spinous process. And then two projections that come off the side of the neural arch right here would be transverse processes. And then every vertebrae communicates with a vertebrae above it and a vertebrae below it. So when you look at how the vertebrae interact with one another, then the vertebrae interact in this manner, so that you can see that we actually have a surface here that is going to interact with the vertebrae. And then if we look at the inside of this area, there's a flat surface there that's going to interact with the vertebrae as well. Okay? So when we look at those interactions, then, and we put the vertebrae in anatomical positions so that this would be closest to the head or superior, and this would be inferior, caudal, or inferior, then this is the superior articular surface of the vertebrae, and it articulates with the vertebrae above it. And then this is the inferior articular surface of the vertebrae, and it's going to articulate with the superior articular surface of the vertebrae below it, so they articulate like this. And then what happens is we have a little notch in the vertebrae here where the pedicel exists on the neural arch. And when you put two vertebrae together, then this actually ends up creating a hole when the vertebrae are put together. So this hole is the intervertebral foramen. And this is the hole through which spinal nerves exit the spinal cord and go out into your body. So what we're going to do is we're going to start with the top of the vertebral column here, and then we're going to work our way down, and our goal is to look at differences that occur in the vertebrae. And so the first thing you'll notice is that cervical vertebrae are small vertebrae, and again it's that weight-bearing phenomenon. And then in cervical vertebrae, the first two are called C1 and C2, and then we could number down through C7. But C1 and C2 also has specific names. So the first thing you'll notice is that when you look at C1 is that the body is largely absent, and the vertebral foramen is fairly large. So C1 is kind of unique that way. So this would be the inferior view of C1, and then this would be a superior view of C1. So this would be the superior articular surfaces that we just talked about with that lumbar vertebrae. And what you'll notice is these have curvature to them, and the structure that would fit perfectly in here would be the occipital condyle that we learned on the skull. So C1 is the cervical vertebrae that articulates with the skull, and therefore it's called the Atlas, because the Greek god Atlas held up the earth, and so, or the world, and so this kind of holds up your skull. So the superior articular surfaces are very unique on C1. And the other thing you'll notice is that we have a little hole here in our transverse process. Now this hole in the transverse process is called a transverse foramen. And transverse foramen are unique to cervical vertebrae. So that's kind of a cool thing, that if you see this hole, you know it's a cervical vertebrae. And I'll show you the importance of that in just a minute. Now if we turn this over so you can see the inferior view, you'll notice that the inferior articulating surface is very, very flat. And that's what allows you to rotate your head laterally in a motion like saying no. All right? And so this surface articulates with C2. Now, interestingly, with this particular vertebral column, this person had a slip disc or a fracture of their neck. And so what you'll look, if you look in here, is they used a rectangular piece of bone to fuse these two vertebrae together, which is an old surgery that they did. And they usually collected this bone from the os cox or the pelvic, the hip bone. So when you look at this particular skeleton's hip bone, you can actually see a thin layer in it where they harvested this bone to create this fusion. Now the unique thing about C2 is it's got this upward projection that we call a dens, or a odontoid process. So if we put C1 and C2 back together, it becomes obvious that what the adens or odontoid process was the body of C1. So the body of C1 has actually gotten trapped to the superior surface of C2 as a cervical vertebrae. And then the dens or odontoid process creates a pivot point so that these two vertebrae can pivot in an action as if you're saying no, which was what we talked about, having those two flat surfaces. So the inferior surface of C1 articulates with the superior surface of C2. Now a pattern we're going to see is that in the cervical vertebrae, these are more horizontal, and as you saw in the lumbar vertebrae, they become very vertical. So that changes the flexion that occurs in the vertebral column as we go downward. So if we look at cervical vertebrae and we continue looking down, then there's going to be a point where we have two vertebrae that look very, very similar if we're looking at them. Fairly long, pointed spinous processes, really flat lamina forming the top of the neural arches, and then these transverse processes. But if you'll notice, when we pull them apart, this one has those transverse foramen that we talked about, and this one lacks those transverse foramen. So this is actually T1, and this is actually C7, and we make that transition from this hole. So what actually passes through this hole is a nerve that we're going to learn called the spinal accessory nerve, and an artery and vein that we're going to learn called the vertebral artery and vein. And so the hole is designed to protect those structures. As we move to the thoracic region, then the one thing that happens is that we have 12 thoracic vertebrae, and we have 12 ribs. And so the pattern then is that every thoracic vertebrae articulates with a rib. So when you look the side of thoracic vertebrae, you'll find a smooth surface on the body that is where the head of the rib would sit. And you'll see a smooth process on the surface of the transverse process where the tubercle of the rib would sit. So for every thoracic vertebrae, we're going to have 2 points of contact with their ribs. So these are called facets. And so there's a pattern. So if you look at this one closely, you'll see that the head of the rib set partly on this vertebrae, and the head of the rib set partly on this vertebrae. So if the facet is occupying two vertebrae at where the vertebrae interact, then we call each one of these a demifacet. So the way you might have seen the word demi used, with women in lingerie and people that sell lingerie, is that if you have a demi-cup bra, it's half of a cup. And so this is half of a facet.